Hello, good morning, all. Can you hear me? My name is Prosper Onyekachukwu. I want to welcome you to today's tele-echo session. If you can hear me, please can you wave your hand? All right, thank you very much. So today we'll be looking at yet another interesting topic on quality improvements. But before we go on, I'd just like to ask that we still adhere to our usual instruction. All the facilities on the call, please do turn on your video and then remain muted until when you need to ask your question. We expect that those practical questions on improving the quality of services that we provide to our patients will be addressed today. And then any other concern, we can also look into that direction. I want to quickly call on the Federal Ministry of Health to give us an opening remark, and standing by to do that, we have Mr. Gabriel Ikulono, who is a research, surveillance, and survey lead at the NASCAP. Please, Mr. Gabriel, can we have you go on with an opening remark?
All right, thank you, Mr. Prosper. I welcome everyone to this platform on ECHO session today on behalf of the Federal Minister of Health and National Coordinator of HIV/AIDS, Dr. Akudo Ikpeazu, and the Head of Strategic Information, Dr. Ade Basharu. Particularly greetings to the representative of the CDC, the representative of APM Phase 3, and all other IPs present on this platform today. I also extend a greeting to a representative from the state, the subject matter expert for today, the facility staff, and the NASCAP team that are here with me. So on behalf of the Federal Minister of Health, I want to thank everyone and encourage everyone to be committed, dedicated to today's topic, developing and implementing quality improvement projects. I'm sure we are going to learn a lot from today's topic. Thank you. Over to you, Mr. Prosper.
Thank you very much, Mr. Gabriel, and thanks to NASCAP Division of Federal Ministry of Health for all your support in making sure that we are doing what we're doing. Again, I would like to call on the representative of CDC Nigeria to give us a goodwill message, and standing by to do that, we have Mr. Essien John, Mr. John Essien. John, please, if you are there, you may want to unmute yourself and go on.
Hi, Prosper, good morning. Can you hear me?
Yeah, good morning, I can hear you.
All right, great. Good morning, everyone. Just want to say welcome to another very exciting ECHO session today on developing and implementing continuous quality improvement projects. I'm sure this is the part 4. Is that correct, Prosper, or part 5? Part 4, I think.
Part 4.
Yeah, absolutely. So for me, ECHO project is like a vehicle that needs various parts and components to make it fully functional. So at this point, I want to say big shout out to Phase 3, the NASCAP team, and all the SMEs for always bringing varieties of ingredients to really spice up this ECHO program. So the CQI projects, the CQI, it's a very critical part of what we do, that will really highlight and bring us to speed on how we can stop fixing and start improving. CQI will show us how changing behavior is more important than changing process. And I think that I believe that as far as I'm alive, no one is better at delivering this than Dr. Emmanuel Ayinagba. So please utilize this opportunity and stay improved. On this note, I'd like to welcome everyone to this session on behalf of the US CDC Country Director, Dr. Mary Boyd. I welcome all facilities, all the SMEs and our partners to this session. Let's pay attention and be attentive. And there's a lot to learn from this particular session today. And I'm sure that Dr. Emmanuel is ready to go with all. Dr. Emmanuel, I just want to let you know that my notes is ready. I'm ready to take all your points as usual. Thank you very much, and I'm over, Prosper.
Thank you very much, John Essen. You have not pretended to express your view over Dr. Emmanuel as one of your best subject matter experts. So I leave that to Dr. Emmanuel to prove that again today. Thank you very much. So today we'll be looking at developing and implementing continuous quality improvement project. And Dr. Emmanuel is one of our renowned subject matter experts, a certified professional in project management and healthcare quality and patient safety. He has been here with us for a very long time, and today he'll be taking us again through this wonderful topic. Dr. Emmanuel, please, you may want to go on with your presentation. You have about 35 minutes or less, and then we'll take the remaining minute for questions and reactions. Thank you. Over to you, Dr. Emmanuel.
Thank you so very much, Mr. Prosper, and thank Dr. Janet for your kind words. Please let me know when you're able to see my screen.
You can see it.
Awesome. All right. So appreciation to the Lieutenant Minister of Health and to our faculty for always coming to this session with your interesting minds to engage with us. So we're going to go through what we call the fourth phase of developing and implementing a continuous quality improvement project. And if you remember, we started out sharing the framework for the model for improvement. And we used that as our construct in determining how we were going to approach this all-important topic. And so when we started out, if you remember, we had mentioned that at the end of the module, the entire module, that the different sections included, we wanted everyone on this call to be able to understand and apply the model for improvement. And by that, they'll be able to understand the PDSA cycle, the plan, do, study, act cycle. And they'll be able to not just understand all of those things, but you would be able to design and document and, very importantly, implement your plan, do, study, act plan. For this particular part 4, we are going to be focusing our attention on the PDSA tool, which is the tool that we use to test change ideas. And at the end of this session, my hope is that you'll be able to design effective PDSA. So a quick recap. In the previous session, we learned the model for improvement, the 3 questions, and the PDSA cycle being the components of that framework. We asked ourselves how we're going to set good aims to actually exactly what we're trying to accomplish. And we also asked ourselves, how would I know that it changed an improvement by introducing measures? And then we went on to talk about the very critical components of the model for improvement, which is changing. Dr. Essen mentioned earlier that it's more important to change behavior than to change process, but there has to be change. So, and we taught ourselves how to generate change areas, the different methods and techniques that can help us at teams working at the front line to be able to generate amazing change ideas that we can test at our facility. But once these change ideas have been generated, what then do we do to them? Do we simply just go ahead and begin to implement them? What if they are not as effective as we thought they were going to be? So in a nutshell, we need to do this model, right? One after the other. What are we trying to accomplish? What do we know about what a change would mean in terms of improvement? And then what change would we make that will lead to improvement? Because we reminded ourselves in the past that there needs to be a change if improvement would happen, but not all change or changes leads to improvement. And that's where the very important tool called the PDSA cycle comes in. It is that tool that allows us to focus on the changes that will lead to improvement. And the way we're going to do that is to test those things. So, but why are we testing? So testing change ideas is a way of trying the change or experimenting, if I can put it that way. I can see the few of you are beginning to frown your eyes, like, how can we be experimenting with people's lives? But as we go on, you would understand what I mean by that. So the test of change would allow us to learn about the potential impact of that change, even before we're able to scale to a level that is huge. It would also carry with it very limited risk in terms of time loss or resource waste, because we're doing it on a small level. It allows us to refine the change because, like a laboratory, we are able to see what the implications of the dynamics of that thing would be. And then we're able to course correct, tweak a few things here and there to improve the quality of the change. It is a very important thing to test because it then tells us that there's something like failure. So in quality improvement, we do not avoid failure. Of course, we don't design ourselves to fail, but we're saying that when we do things and those things don't give us the results that we desire, we just have learned how not to do those things. And we believe that as you improve, you'll be able to get better results as you go on. So the PDSA cycle is a useful framework for planning, first of all, and carrying out, and most importantly, learning from a test of change. Don't ever forget that. So you remember Thomas Edison saying that he did not fail 1,000 times that he was trying to invent the filament of the bulb. He just found 1,000 ways of how not to make it. So that's the mindset here. This is very critical to double click on, because if we are afraid of failure, then we will not start, we will not test it. We would be paralyzed. We'll stay back waiting for that silver bullet, for that idea that will just transform our system. It's not that those ideas don't exist, but they are created through the process of testing. So the principles of testing, very quickly, 3 key ones I will focus on this call are skill, conditions, and plan. By skill, we mean that, like I mentioned earlier, a test is conducted within a small space, a small skill. And then as you learn more about your system, about that change, about the processes, about what behavior needs to change, you keep improving, you keep increasing your scope and your skill. So you do all of that based on the learning you're making as you test. The second principle of testing is the conditions. So you don't test your change in one condition and then say, wow, this is how we're going to be doing it. You don't test your change in a ward in a hospital that has maybe 30 wards, and then you say, no, this is the way to do things. So you must ensure that you test the thing in different conditions so that you keep refining it, and it helps you to get better quality out of that change idea. And the final one is planning. This is important to double click on, because if you don't plan that step, then you are going to fail, not in the type of failure I described earlier. You will not know what worked or what didn't work. You will not be able to refer to your plan. So you must plan your test, and very importantly, also include data collection in your test. This is important because remember what we said, that the QI space is a data-driven space. So we do everything rises and falls on data in the QI space. So I just messed you. The PDSA means plan, do, study, and it's usually small steps of change to accomplish your goal. What are the benefits of PDSA? First of all, like I mentioned, it improves your confidence that the change will result in an improvement. Coming from the third question in the model for improvement, that is, what change are we going to implement that would give us the result we want? So the PDSA will give you the confidence you need, because you are able to then tell stakeholders, oh, we started testing this change in 1 word, and then we did it in 4 words. We tested it with males, we tested with females, we tested on a weekday, we tested on a weekend, different conditions, and we kept getting better and better results as we go on. So your degree of confidence, which is your ability to be able to take a change and truly run with it, will be increased through the PDSA cycle. It also means that the PDSA cycle helps you to show the result of your improvement from that particular thing. So you're able to say, I did A, B, C, and then I got 1, 2, 3. It also accounts for the kind of manipulation you can do within unique environments. So if they did something in Cameroon or Ghana or in the US, your PDSA gives you the ability to take that idea from that environment that has its own nuances into your own local context, which is unique in its dynamics. So the PDSA helps you to bring on board things that have worked in other areas, but before you just install in your system, you're able to test how your environment and the dynamics would react or respond to that thing. The PDSA allows you, remember what I said about resource use, it allows you to evaluate your costs, the benefits, the impact, and oftentimes unintended consequences on a small scale. So you're not basically bringing the party graph from Malawi and install into this space, or bringing the treatment guideline from another environment entirely and install into your system, and then you blame yourself because you didn't get the result that you set out to get. The final one, which is very key in human psychology and the management of change, is that the PDSA cycle allows you to lessen the resistance that you get from people. I would extend this a little bit further. So if you have 10 teams that are working within an environment, instead of bringing a change and saying, calling a meeting of 10 teams and saying, everybody, this is how we're going to be doing things going forward, you're able to, based on your understanding of the system and how those things work, you're able to pick the team that would work with you the best and say, can we try this thing for the next 2 clinic days? That way, people will not react. And so if you do that, the next 2 clinic days, you document the changes you are saying, you have your data, you involve another set of 2 or another set of 3. If you know it, you're able to show with evidence, your data documented, that this thing that I'm recommending that will change you is actually a change that will lead to improvement, as the data shows. Now, at the beginning, you want to test on a small scale. So the kind of questions that should run through your mind right now is, okay, what are those changes that I can test on Monday or by next Tuesday? We have the rule of the thumb here. So the rule of 1, don't say you want to test a change in the entire hospital. Rather, think about a clinic in a hospital that has multiple clinics. Think about a department or a ward in a hospital that has multiple of those. Think about one process in a multi-process system. Think about one set of clients, one set of patients in an environment where you're catering for hundreds, if not millions of patients. So that's the way to go about it. Think about the change you can implement soon, that's by next week, but also think about where the scale that you're going to implement that on. So this is important because I put this word there, the word implement. So when we're talking about PDS, it's like implementation is a criminal word to use. For PDS cycles, we only talk about testing, and I'll tell you the difference in a bit. All right, so when you have a system, it definitely means you have processes, and within those processes, you would have bottlenecks or some problems coming. Before you're able to design your PDS cycle, you must have an understanding of the system. If you do not have that, you must speak with the people that have that understanding. You must engage with people. And in your instance, the stakeholders that you must also engage with include the people living with HIV. Because they would help you understand what their challenges are. You're not sitting in your offices or your clinic just designing them around them. So nothing about them without them. That's the slogan. Nothing about them without them. So as you look at your processes, you look for opportunity for improvement, please don't jump to solution again. Meaning you found a problem, and that's PDSA, right? Another way of PDSA is don't jump to the solution from the problem. You must have an understanding, and that's what happens when you tap into the resources that your teams, the stakeholders, the multidisciplinary team, the patients in your clinic are involved with. Now, remember we said you must plan your PDSA. So you and your team must sit down, think about the intervention, think about what you need. You must have an hypothesis. You must anticipate what will happen if you make this change, and then you must be able to predict. So you must plan what you want to change in that system. Who will be involved? When would they be involved? Would they need resources? If somebody is going to be tracking waiting time, for an example, and you don't give them wristwatch or clock or whatever it is, that may be the only thing that will make your PDSA test to fail. So how long would that be? When they're tracking waiting time, would you agree on how you're going to document the waiting time? Is it from the moment they come to the institution to the time they leave, or are you tracking from the moment they get into the facility to the time they leave? All of those nuances should be critically looked at and agreed on before you start your change. Don't assume that we all have an agreement. Or don't assume that because you're told Emmanuel that is the one who will be tracking time, you expect him to use his brains to bring the wristwatch to work. You must ensure that if he's going to use his wristwatch, then everybody agrees to that. So you make sure that everybody on your team, on that team, no matter how small or big, is thoroughly on the same page with you and they understand what their responsibilities are and you have their buy-in. So document the process as it exists, the flow chart as it exists. This is what you have. Then engage with your stakeholders, determine what the future should be. So you create a vision of what the future should be. Make a prediction. If I bring in 2 more clinicians into the clinic, I will be able to see times 3 the number of patients that I see, and that will reduce the wait time. Right? That's your prediction, but you don't know if it's going to work. Throwing in more resources doesn't necessarily mean you're going to get better results. Then collect, the current system is that you have a baseline data that speaks to what the problem is. If you do, share your plans, share what you want to communicate with people, and let them have an understanding of what needs to be done. This is a reiteration of what we said earlier, people knowing what is expected of them, where, when, having the right tools that they need. They have the right time. Their supervisors have released them to come and shadow someone in your clinic or to come and stand in for somebody, just as to test those, ensure that people have all that they need to get the work that they need to get done. We talked about flowcharts and we talked about this in the past, but basically this is just showing you visually what your current state is, and then you're creating a future picture of what it needs to be so that you can then ask yourself, what do we need to do to move from point A to point B? Remember what we said about PDSA being, please don't jump to solutions. It also means that you must always do a root cause analysis of what the problem is, so that you're not applying quick fixes to the problem on the ground. If what you need is a different orientation of how people do their work, then address that. If what you need is more resources, find out what that is and address that as well. So a typical example, problem identified is in this particular clinic, they found out that 0%, none of the newly identified or old index HIV cases were receiving family index testing. They found out when they checked in January of this year that happened between the last quarter of 2022. So the aim for this project is to increase that family index testing rate from 0% to 30% by September of this year. So remember SMART aims, they set an outcome measure to be the percentage of HIV positive index cases who receive family index testing service per month. They changed the ideas on what they want to introduce is that they are saying, somebody comes up with the idea that based on the root cause analysis of this situation, they believe that if they introduce or offer family index testing services to every newly identified case, they'll be able to ensure that nobody is missing that opportunity. But they also want to mop up the old cases. So they're saying every week, 10 old cases clients are going to be offered this service. That is what they think would, move the needle in the right direction. The process measures would be in those 2 fronts: newly identified positives and the percentage of those who are getting the family index testing, and percentage of those in the old pool who are getting that testing done every week. So who are the people who are going to be involved in these small sets of change? Adherence counselors, ART site coordinator, CSO testers, and medical records officer, according to this system. It may be different in your own environment. In your environment, it may require that even for this small test, you need approval from somebody. So if you would have to put that there. How? So they're describing how they're going to test it. So they're saying adherence counselors are going to offer this service to every newly identified positive every week. And so there will be a document that they capture this particular data on. And also that these same counselors are going to generate a list of 10 old clients due for clinic visits the following week from the appointment register. So as I'm mentioning this, you're asking yourself, in your current system, does the adherence counselor have access to the appointment register? If the answer to that is no, it means whoever has the access to that must work with the adherence counselor. So I think you're following how these whole things work. We're saying that the adherence counselor is going to make phone calls to old clients now to offer family testing so that when these people come the following week for the appointment, the service is going to be ready. The assumption here, again, is that you're giving the adherence counselor the phone or bought credit or they have access to a hospital phone or whatever it is. Now, this sounds also pretty like it shouldn't anybody be able to use their brain, but it truth is, if you're going to test this thing the way you envision it, no detail is too small to capture here. So you have to walk through the process all the way. Now, step 2, so that's the plan. What I just showed you is the plan of the PDSA. The do is very similar to the plan. The difference is that you are doing. Remember I mentioned in the plan phase that this is the data we're going to collect. We're going to be collecting the percentage of those indicators that we put in there. And the person who will be responsible for that in this instance is their direct catalog. So the do phase is do the exact thing you plan. Use that plan as your blueprint. Ensure you collect data, because there's another phase coming that will require you to look at the data that you've collected. So during the do phase, you are executing what you plan to do. You're paying attention to the things that went as planned. You're documenting the things that didn't go as planned. You're documenting your learning from that process. So Emmanuel is the adherence counselor. He, for one reason or the other, forgot to connect with the appointment, the person who has the appointment register, and so he couldn't call those people. That use that text, so you must document it. So do we want to send a reminder in our next cycle? Do we want to send a reminder to Emmanuel? Do you want to ensure that somebody checks in with him? Whatever I think you need to do. But if you don't document it, then you're going to run into problem. You try to now do the review of what you have done. So do what you have tested, what you said you're going to do, which is the testing, back your data, be it quantitative, be it qualitative, make sure you have that data. So the work plan is what you planned, the test phase is the data collection tools that we use during the do phase. The next phase, the third phase, study. So this study phase becomes useless totally if you didn't have a prediction, you didn't collect data in the plan, you didn't plan to collect data, you didn't collect data in the plan and do phase respectively. You have omitted very important key steps in this process, because at the study phase, you're sitting back with your team to say, this was what we planned to do, this was what we predicted would happen if we did X, Y, Z. Did that happen? How have our expectations been met or not met? So the study phase is a very important phase, and you're also documenting more to say, yes, we met our expectation. We said we're going to increase that rate by 15%, and best we did, increase it by 15% or 20% or 5%. Why did that happen? What can we learn? If Emmanuel didn't schedule the testing, what do we then do this week? Now, before I move on, it's important for you to review what you're learning, because this is where you're going to tell yourself, it worked, it did not work. If the change did not work, it's okay. But let's know why it didn't work. If it did not work because we didn't do what we said we were going to do, we have to go back to do what we said we were going to do, because the problem may not be with the change. The problem may be with the planning, the execution of that change. So that's very, very key. So some of the tools we would use during the study phase, very common run charts, the time series, histograms, bar charts. Of course, whatever it is that you have done qualitatively, the experiential quality surveys, key informant interviews, and focus group, if they're relevant to the work that you're trying to do. Then the final phase of the PDSA is the act phase, which basically says, now that you have planned and done and studied and learned through the process, what are you going to do to this change that went into this process? And so you're going to be asking yourself, what should we do with our results or about our results? Is the change we saw when we were studying from the graph, from the pie chart, from the analysis of the qualitative data, was that an improvement or was it not? Do we need more data to be able to be confident about making a conclusive statement about such a change? If we want to adopt this change because it led to improvement in this step, is it sustainable? What do we need to make it sustainable? What do we need to make it scale? What else do we want to test? This question comes in handy when there are multiple factors that are contributing to a particular influence. So we usually say that in the act phase, the three things you can do are to either adapt the change, tweak it, improve on it, review something, or because it worked, or it gave you some results, or abandon it because it failed. So we'll go back and say, okay, right, we can confidently, based on the output or outcome of this test, say that this particular change idea, it might have worked in the US, it might have worked in the UK, it might have worked even in Ghana, but it's not going to work. In fact, it might have worked in Nigeria, some other institutions or facilities. But in this context, based on this finding, it's not going to work. So we can abandon it. Or we can adopt it and say, yeah, great, it's exactly what we're looking for. Now, how do we standardize this? So you keep testing. So if we tested only during weekdays, let's test during weekends. If we tested only one clinic, let's test another clinic. Remember that those principles of testing. So the situation. So now we test in different locations to be able to improve our confidence level. PDSA, like UI, is continuous. You keep doing it, you keep iterating, you keep tweaking things until you're able to sustain it and then operationalize it. That is when you now use the term implement. It's a test, no matter how long it takes, until it's been sustained and you can now make it become your regular way of life, operationalize it. All right? Now, when you've looked at the data and in your act phase, you're determining what to do, whether you're going to abandon, adopt, or adapt, you need to, from the data you've seen, this new data, which is better than your baseline, determines your next step. You continue to track, you don't make sudden changes until you have better data that speaks to you about what's going on or data from the patient. You keep repeating the initial plan with slight modifications, like the example I gave to you, it's a matter of doing what we're meant to do, what do we then do? The example I gave to you also requires that you're doing, remember, it's a thing. So typically, it means nobody was calling patients for their appointment, hypothetically, right? So if we're going to operationalize that, we need to check with account or whoever is responsible for finances to say, do we have imprint that will cover this thing, or how much are we spending? And somebody may say, well, you see this call thing, I'm not so sure about it. Can you guys go the route of SMS? Or do you want to just use the office or hospital internet to do WhatsApp messaging, whatever it is? So you keep going back to refine. If it works, you keep going back to drawing board to refine to get the result that you need to get. So this picture is what we usually use to depict that. You rarely will find a PDSA cycle standing alone. It's always a PDSA round, as we call it. So you start your thing, you plan it, you test it. It's based on an anecdotal chain. You improve it, qualitative chain. You begin to get number. The places where you see the test is done in one place here, 5 places here, 20 places here, and then you're doing a systemic change, right, across all the facilities. But an important component is that data collection is on, because every decision you're going to be making or not making will be based on the data. So your checklist, your training plan, your sustainability plan are part of the tools you use during the act phase. Now, to talk about your mind on what we said we wanted to achieve, the 3 questions, PDSA cycle, model for improvement, that's what it is. And in the journey, in the first 3 steps of our journey, we went through the 3 questions. In this 4th step, we've gone through a PDSA cycle, which is basically a tool in your hand to help you test the change ideas you came up with as the instrument or factors that will lead to improvement in your system. And so at the end of this module, which is now, we believe that you have a good understanding, a good grasp of the model for improvement. You understand the PDSA cycle. You're able to design, document, and implement your PDSA plans. You have those understandings, and you're able to reconcile what you have learned today with what you have learned in the previous session, 1, under QI, but you're also able to reconcile what you're learning in this session with other processes within your clinics, your interactions with your patients, the challenges you may be facing, some of the feedback you have received from your funders regarding the dynamics of your data. So if you've been improving in a particular area, for whatever reason you are no longer improving, what needs to change? What are those change ideas that you need to bring in? And how are you going to test that? So with that, I think we've come to the end of this session, and it would be very good if we can get some questions, contributions from the field regarding how this would play out in your setting. Thank you so very much. I'm going to be on standby for any questions or comments.
Thank you very much, Dr. Emmanuel. You may want to stop sharing your screen. Thank you very much, Dr. Emmanuel. You may want to stop sharing your screen. Wow, what a very elaborate presentation on QI. And I'm glad that a lot of facilities are already part and parcel of QI. I also believe that we have both national clinical mentors that are in charge of different states, and then we also have state clinical mentors, and everything that clinical mentors are doing are geared towards quality improvement. So I would want to think that most of those clinical mentors, regarding what they are doing and regarding the meetings, that this is a good platform for us to build on what you're already doing, and then have an expert like Dr. Emmanuel provide you further perspective, guidance, and all of that. We do receive questions from QI team about some that cannot be improved, some that your facilities are not supportive, and a whole manner of things. This is the time to ask, are you choked? Are you having a problem in your facility? What are the things that you need? The platform is here for us to guide you through. So can we take questions? Do you have questions? If you have questions, please, I will encourage you to use the Zoom platform and raise your hand, or you can also drop it through the chat box, but preferably use the Zoom platform to raise your hands and I'll be calling you. Hello, have I been speaking my own language? Can you all hear me? Please wave your hand if you can hear me. So, Epim Benue State General Hospital or Tupo, is it QI you are doing there? I can see some things happening on your decks. Is it QI plan? So, okay, straight to the point, there are some persons that have indicated to ask questions. So MPHC Omoku, can you unmute yourself and ask your question? MPHC Omoku, I've enabled you. Please unmute yourself and ask your question. MPHC Omoku. You raise your hands and I've enabled you, and then you say can't talk. Okay, let's see. Let's take a question on WhatsApp. I mean, on the chat. So this is from Dr. Samuel Onbiko. He said, "Thank you very much, Dr. Emmanuel. Could you throw more light on the science of prioritizing problems where we have more than one identified problem to work on?" So this is talking about prioritization where you have plenty. Of course, there must be a lot of problems. So how you can prioritize, I don't know, but if you're a clinical mentor or if you have undergone any QI training, you would have learned about prioritization method. But let me allow Dr. Emmanuel to give specific answers to that. Dr. Emmanuel, please, over to you.
Thank you so very much, and thank you, Dr. Samuel. So wonderful question and very relevant question in anywhere in the world, but more importantly in our environment where we face a lot of resource constraints and very wicked problems. But to your question, so the first thing is there are several factors to consider when, first of all, I hope you know that you need to prioritize problems because you can't solve all problems, especially at the same time, right? So it's important that you are skilled in the process of prioritizing the problems that you solve. But so that you don't end up either solving a problem that doesn't exist or solving a problem that doesn't give you the kind of value that you desire in your system, you need to learn how to be able to prioritize problems. And there are several different methods we can use or tools, but the guiding principle underneath of those prioritization processes is one, the problems that you have, can you group them into who is affected by the problem, right? And what is the volume? So let me give you an example. So you look at the data that you have and you see something occurring frequently, and you look, another problem comes affecting other people. Problem A affects 3 people out of 1,000. Problem B affects 500 people out of 1,000. Of course, that's just one element. You don't just jump and say, let's go and solve the problem that is affecting more people, but that's a consideration. So who is affected and what's the volume of that problem? Second consideration is there are some things you desire to do that you don't have the capacity to do them. So this particular problem, do you have the capacity, which of the problems do you have capacity to do, right? So if you need to, for an example, hypothetically, build a new structure to be able to solve a particular problem, you don't have the funding for that. That is a no-brainer. You already know that that's a problem you pack somewhere. What will be the impact of solving these problems? So if you propose solution to a particular problem, and that solution would influence your entire patient population, versus preparing a solution that would make a few people, 5, 10, 50 people, right? That is also a consideration that you need to put your mind on as you're trying to then prioritize. In the end, in terms of capacity, we're talking also about your team. What can your team handle? If you say, well, I want to test this, but it will require me to hire 5 new doctors into this hospital, do you have that bandwidth? So as you consider these elements, who it is affecting, the volume of persons affecting, what will be the impact of the solution, what are the risks associated with the solution to a particular problem, what is the capacity of your team in terms of resources, time, ability to provide the solution, you then create a matrix that would help you in a scientific way. So you're doing this to help make sure that you're solving the right problem, but you're also doing this scientifically to be able to justify or make a business case to funders or your management that truly this problem should be solved. And the final one I would say is, who cares? The expansion to that is, who does this problem matter? Who is concerned about the solution? So, and this comes in when you're trying to manage people upward. If your line manager or your facility manager or the owner of the hospital, whatever it is concerned about certain things, when they hear it, they are excited and they're like, oh, what do you need to solve this problem? You don't need to be thinking about buying and engagement and all that. So you also need to think about that. Who does this problem matter to? Is also a critical question to ask as you create your problem prioritization matrix to help in your decision making. I hope I've been able to answer your question.
Thank you very much, Dr. Emmanuel, and that was well detailed. Also, just to add, you also consider the feasibility of that project so that you don't take up improving power supply in your facility when the country as a whole has not improved it. You cannot buy gen. You cannot. So there are some very lofty projects that when you look at it, you see, no, this one is not within the confines of the quality improvement team. So that also needs to be improved, because some people have actually asked us that they want to improve on power supply. There is no lights, they cannot do this on the system, they can't access the EMR and the rest of it. So that's also a very key to consider. So do we have other questions? I expect more questions on this, because QI is what we do every day at our facility, and there are daily gaps that we identify. Okay, we have one of our senior colleagues also, Dr. Magnus, that wants to say. So Dr. Magnus, please, over to you.
Okay, thank you very much, Dr. Manuel. Thank you so much, Prosper. For us, the HIV world, we all understand that our key problems are surrounded with program implementation, when we begin to look at our challenges that start running from our case finding, especially now that we're trying to do age disaggregated case finding. And then by the time we get this client, we begin to look at how to retain our clients. We have challenges from that angle on how to retain our clients. Then we begin to look at the challenges of, okay, how do we improve the number of clients that keep to their appointments, is what we term appointment compliance system that we're always trying to improve to meet up a certain percentage. And then after that, we begin to look at how do we begin to decrease those who missed appointments. So those are normally the key challenges that we really need QI interventions for us in the HIV. And then when you look at that too, you move on to the next stage, which is our viral load suppression, how to ensure that we have up to 98% suppression. And now we're moving into the new system of low-level viremia, where we are expecting that we want to make sure that we have people suppressed below 50 copies per mil anytime we conduct the virus. So our QI issues are cut across from that first 95 up onto the third 95. So what we will want to plead as we continue with this program going forward, what we equally plead with Phase 3, Prosper, and team, that probably going forward, we will begin to pick specific, those challenges that have to do specifically with issues related directly to the program implementation. We could pick 1 or 2 or 3 and begin to maybe say, okay, how do you try to solve this problem? For example, how do you ensure that you improve your appointment compliance system? If you're having like 63 in a week, how do you improve it to 93? So I want to say we very much appreciate this presentation. I believe that the facilitators very much appreciate, but our targeted programs, because what you have spoken so far, it cuts across everything. But we want to plead that as we move forward too, if we become program specific, okay, just like I said, how do we improve our case finding amongst the pediatrics? How do we improve our case finding among 0 to 4, or our maybe 4 to 9, or maybe how do we improve our clinic attendance for our 10 to 19 and all those. So we want to say a very huge thanks to what you've done today, and plead that going forward, we may begin to think, because you have up to 4 or 5 sessions, don't be too disturbed if we increase your sessions up to 10, because we want to begin to target specifically and see, because by the time we give specific, you will see the no quantum of questions that are going to come, because almost every facility, there is no facility that doesn't have a challenge across first 95, second 95, and third 95. So we want to very much appreciate the models that you've given to us here. We'll go back, we'll begin to implement them, particularly targeting, especially the one that you have told us how to prioritize our problems, because that prioritization, just like Prosper said, it's the most important. I can't be battling with an IIT issue and I begin to think of fuel that is not, when I know that there's even no diesel in the country and all those kind of things. So thank you so much, and we hope that going forward we'll have more of this that will be program specific. Thank you. I just wanted to bring that little bit of input. Thank you. Yeah.
Thank you very much. Dr. Magnus, and thank you for that explaining that. So just to add that about having maybe a national QI project or one that is program specific, we have done that in the time past. Of the time we had EID, QI on EID. When we heard from the national data, we found out that the early infant diagnosis was very poor, so we needed to do that. And then with ALT initiation, that was before the advent of test and start. And then when we get that, we find out that some facility will tell you our ALT initiation is top notch. We don't have a problem there. Some other facility will tell you our EID, we have just about 4 or 5 patients and we are following them up. It is top notch. So when you make it a national, find out most facility, it is not their problem. So that's why we now leave it open for you to identify the problem that is specific to your facility. And with the clinical mentors that are scattered across both national clinical mentors and state clinical mentors, we also encourage them. We have probably a program-specific QI, but when you go down to your facility, if you have a facility, a key problem at your facility, you also develop QI and address it. What this topic or this QI is trying to do to us is to give you that capacity and that enablement to be able to, at a glance, identify a problem in your facility. Also, at a glance, work with your team to develop a QI plan to address it, right? If we have that capacity, you don't even need for your state to wait to come and tell you, okay, we feel there is a gap here. You are doing it, we take ownership of it and begin to improve on it. So let me call on Arimu John Tunde. Please, can you unmute yourself and ask your question? You are also a national clinical mentor. So I'd like you to affirm or disagree with this thing that we said. Are you driving a specific program QI, or you are encouraging your sites to identify problems from their facility and then you guide them to do that? I know you are a national clinical mentor in Gombe and you have so many state clinical mentors under you. So please, I'd like you to speak to this directly.
All right, thank you, Dr. Emmanuel. It's always a delight to listen to you. And I followed every bit of the discussion. I don't have a question. I just want to add my voice to some of the points that were made. First of all, just from observations from the field, sometimes when you get to facilities, you want to assume that you know the problem more than the facility. So you must practically allow the facility to understand their own problems. And they must understand that there can be multiple problems, but they must choose the one that will affect the program in a way that may have a cut-crossing effect. And that's why using the prioritization matrix is very, very important. I also heard Prosper try to say that sometimes you try to look at some things I think is a problem, and it may not be a problem. The problem is there are some data that you see that will look picture perfect. But if you ask the facility, how did you get to that result? There's actually no process to it. So at the end of the day, CQI will make you perfect your data, and it will also make you understand the process that leads to that perfect data. And at the same time, make you to build a structure that you can work on so that at every point in time, that structure will assist the facility to continue to make progress. So even if the data looks very nice, if your variable suppression is 97%, for example, do you know the process? Do you have the process that took you to that level? I think those are the important things that we need to put an eye on while we are doing this CQI project. So thank you very much, Dr. Emmanuel. Just a delight always to listen to you. Over to you.
Thank you very much, our able, faithful national clinical mentor in Gombe, always there. And it would be nice to recognize such diligence and steadfastness. So thank you, Dr. Aremu John. So let's have CIHP Mieti Hospital unmute yourself and ask your question. CIHP Mieti Hospital.
Okay, good morning, everyone. Thank you for this wonderful presentation. Mine is not that a question, is a matter of concern. My concern here is regarding the EMR tools. You know, we here at the facility, like for this migration, there's a migration that was done from from enterprise to POC database. So our POC database is working perfectly, but the main problem we are having is concerning reporting the CMM tools, that's commodity modules tools. You know, when you wanted to start your database in the morning, you understand, there's one module called Jasper. That Jasper is used to delay the database from starting up. You understand? It will take you like a 10 to 15 hours before your database start up. You understand? And most of our systems are old. You understand? They may run out of battery or we run out of power supply and so on and so forth. So I wanted to so my concern here is that to tell you people, please, if there is a way people can make it so that it will be easier for us to be reporting our commodity models in time, because this is really challenging us. Thank you.
Okay, CIHP Mieti. I'm glad Carlos Samuel, the person supporting you on ECHO is here. But I want to request that this is a data related question that maybe I will refer you to our data person and the health informatics team, and they'll be able to address it and get it sorted out. So if you can send me a mail with the details of your consign, and if you have Carlos' email, you can copy him on the mail. Otherwise, you just send to me with this. As soon as I get that mail, I will link you up with someone that will provide support to you on this EMR India related issue. I don't know if that will address that.
It's okay.
All right, thank you very much. Please don't forget, I suppose you have my email, so do that quickly. So at the moment, in the absence of further questions, I want to call Dr. Emmanuel. Do you want to give us a final word, Dr. Emmanuel?
Well, just to say thank you to 53, thank you to CDC, FMOH, and importantly, all of you at the front line doing what you love, doing the best. I just want to keep encouraging us to maximize this platform. And there is a reason why you have access to all the recorded sessions. So please avail yourself of that opportunity to keep improving yourself. We can't say thank you enough for how you risk your life and stand at the front line. So thank you so very much, and God bless. Forward.
Thank you, Dr. Emmanuel. And let me bring in John Essien from CDC for a final word. John, please, can we have you? Hello, John, are you there? John Essien? I think John is out. Okay. So let's have the Federal Minister of Health give us a closing remark. Mr. Gabriel Kulono, if you are still there, can we have you please do that?
Yeah, Mr. Prosper, thank you so much.
Thank you very much.
Yeah, I want to especially thank the CDC on behalf of the Federal Minister of Health for their continuous support to make sure we actualize this ECHO every Thursday. The CDC, the APM Phase 3, I want to thank you. I want to thank all the IPs present on this platform, the facility staff, the NAS captain, and every other person that is present. I want to thank you. I appreciate you all. Then I especially want to thank Dr. Emmanuel Ayiniba for this great topic that he has taken today on developing and implementing continuous quality improvement project, part 4. Yeah, like you said, he made us to understand that quality improvement starts from planning, at the planning stage of our projects, at the implementation, every stage of implementation. And he also mentioned data collection, developing questionnaire review. All this one is introducing quality, improving quality, and the data itself, data quality improvement. And we know that the receiving end is quality of care, providing quality of care to our clients is very, very important. Sometimes I look at the 5 Street project, ECHO. They continue to imbibe the culture of continuous quality improvement, making ECHO accessible, making the learning very, very important to us. So I want to thank Mr. Prosper and the Vice Chair for the continuous quality improvement on ECHO itself. So on behalf of the Federal Ministry of Health, I want to thank everyone that participated in this ECHO platform, ECHO session today. Thank you so much, and thank you. Over to you, Mr. Prosper. Thank you.
Thank you very much, Gabriel. Thanks also to NASCAP. You guys have been doing great work, providing policy guidelines and directions to the project. Thanks to Dr. Bashirun, who is always there to support. To Labake, to Mrs. Mayake, and the rest of the team, we appreciate you. And over here, I have with me Dr. Magnus Odido. We have Miriam Olawa, we have Dr. Naji. And then we have Dr. Emmanuel, who paid us August visit. In fact, Dr. Emmanuel is in the building. Dr. Emmanuel, we greet you. Thank you very much. So we look forward to seeing you again next week, where we'll be looking at yet another interesting topic. So thank you very much, and do have a great day.
Thank you, and thank you.
I've also shared the link. You can access the link on the chat box.